I have 20 minutes. So what I was going to focus on today is the scope of pain and substance use in the elderly. Talk a little bit about opioid place in therapy, and then talk about mitigating risks. So if you're going to prescribe an opioid, what things you would do or should do or could do to kind of help mitigate risk prescribing this type of medication. So just to talk about pain in general and the cost of pain, this is a very central thing to many patients. There's over 100 million people that have persistent pain in the US. And when we look at our geriatric population, pretty well one in 3 patients have a chronic pain. The total cost actually is staggering. It's $600 billion per year to kind of manage pain, and that includes direct patient care, loss in wages, etc. And it actually is the cost of managing pain is greater than the combination of cardiovascular disease, diabetes, and cancer together. When we're looking at adverse drug reactions that are related to opioids, this is also very costly. So patients that are admitted generally, stay longer, on average about 3 days longer if they're admitted for an opioid-related adverse drug event. Their cost of admission is more expensive too, approximately $5,000 more, and they have a greater risk of readmission. And then when we're looking at actually preventable adverse drug events, so this is something that I focus in on, approximately a third of those preventable adverse drug events were related to opioids, specifically or mostly are often due to morphine. So one thing that I wanted to stress that I think we all know is that as we the increase in substance or drug exposure for a patient always increases their risk of potential opioid use disorder or substance use disorder. So when we're looking at, and this is relevant to our elderly population, and it often is very underreported or because they have so many other comorbidities that sometimes this flies under the radar until there is actually something that, kind of significant happens. But when we're looking at kind of prevalence, 3 out of 5 patients, elderly patients, actually are taking painkillers regularly. And when we look at our Medicare patients, which a good portion are geriatric, 1/3 of those, received an opioid in the year of 2016, and that's a very consistent number for this year as well. 1 in 5 older adults take a CNS medication, and I'd argue actually in my clinic, I think this is really lowballed. I would actually put it at a 3 out of 5 in our clinic at least. 10% of patients are reported to be using or taking a benzodiazepine. And then also looking at specifically alcohol. So 50% of our elderly patients report consuming alcohol. And when we look at those patients that are actually consuming alcohol and we look at their comorbidities and other lifestyle habits, 50% of those patients, their drinking habits are considered actually harmful or hazardous. This study looked at opioid-related ED visits. So elderly patients that have presented to the ED with an ICD-9 code of opioid misuse or opioid overdose. And this was in 2006 to 2014. And this was during kind of, as we were kind of ramping up with our different ways we were addressing the opioid crisis. But it does emphasize that, even though the numbers are very low, that there is, or there was at least, an increase in concern about this. And this rate actually exceeded the reported rate for younger adults at that time. And this dotted line, by the way, is just general use of the ED by elderly patients. So that stayed constant with this increase here. And this obviously is potentially underrating or underreporting our elderly population's problem with opioid misuse, because there's other, they can see the physician provider's office. They have treatment centers also that patients can utilize. So opioids aren't all bad. In fact, there are some advantages to using them, and so I always like to kind of stress that. So if we're looking at opioids in comparison to other alternative options, sometimes they're actually, especially those patients that have fixed income, they're actually a very affordable option. So a lot of topicals, which we like to use, can be expensive and out of patients' price range. Some of the ER formulations, those are often very expensive. Also for elderly population, invasive procedures, surgeries are not an option or not a good option for elderly population. So opioids actually can present a safer or option for those people. And they do have very low risk of end organ damage. So GI, renal, hepatic, cardiovascular issues are not really something we need to think about. Besides the dosing for renal for opioids, not something we have to worry terribly much about compared to, for instance, NSAIDs. And they do help, obvious things, decrease disability, increase mobility, so therefore increasing quality of life for patients. So a lot of patients, if they're, prescribed appropriately, they really enhance life. On the alternate, these are the things that we all are aware of. So they do carry some significant problems for elderly population and can exacerbate kind of comorbidities that they already have. So mitigating opioid risk, so which is foremost to everyone's goals. So there's two things that happened during the opioid crisis. The DEA and CDC, as we all know, kind of drilled down on this. So the DEA started to restrict access to medications, reclassifying hydrocodone to C2, added tramadol as a controlled substance, which is very helpful because that now puts that medication on the prescription monitoring program. So we all now can kind of get a better idea of what controlled substances patients are using, and therefore be safer in our prescribing habits. And the prescription monitoring program actually is active in every state except, I think, Missouri. And you also can access it, I think we probably know this, but you can also access others, mostly, at least in Washington, other states' programs as well. So if you have a patient, for instance, that is traveling from or coming from California to live with their daughter now, you can look, actually track back 5 years and take a look at their use. The DEA also at one time tried to propose setting manufacturing limits on opioid production, which didn't really go through. The CDC in 2016, I think we all know, started to standardize actually how we are prescribing. And so they talked about, or they have set up rules that each state has incorporated into their own kind of set of rules on how we're going to monitor, educate, and stratify risk for our patients. And the most important thing that the CDC has been trying to hammer home is that opioids are not first-line therapy for chronic pain. And then individually in our clinic, using a multimodal approach to pain management is often very helpful for opioid sparing practices, which we'll talk about in just a minute. But that is, obviously a very good strategy. When we're talking about multimodal approach, I think we're all familiar with this kind of probably schematic, but just again, CDC is stressing non-pharmacological along with pharmacological modalities in order to best manage a patient's pain. And some of those other modalities, unfortunately, are not often as optimal or easily accessible to our elderly patients. So cognitive behavioral disorder, or certainly cognitive behavioral therapy, weight loss, both are very effective or helpful in all types of pain. But for some of our patients that are old and can't get around as much, or don't have transportation, those at least historically have been a little bit more problematic for them to kind of access. Yoga, Tai Chi, and exercise in general, all have been shown to be helpful in pain management as well. And part of the reason for this multimodal approach I think, and you may have seen this schematic before, and this is looking at leg pain, is that it is multidimensional, multi-causal. So there's the kind of physical reasons why a patient may have pain, but then focusing here, these things also can be contributors, and they also can be challenging for pain management. And if not properly managed, and of course opioids are not ideal, or not the drug of choice for these problems, you can kind of set up this vicious cycle for patients. So one thing that I have noticed, or try to focus in on, is if, and we do this because we're so focused now on polypharmacy and deprescribing, which is great. But if you have, for instance, a patient, you start on a narcotic, and even with titration up, they're just not benefiting or seeming to benefit, or even with gabapentin or some other modalities, it might indicate that obviously, or not obviously, but it might indicate that, for instance, there's something else. Their depression is not being adequately addressed. And if these are not adequately addressed, then their patients again are they are at risk for substance use or opioid use disorder, because they will use what they have, and then that's creating a bit of a problem. The other, just when we talk about multimodal, so multimodal approach as to what kind of modalities we're going to use, but also when we're looking pharmacologically at pain management, lower back pain being an example, there actually is, for some patients, a very significant, for instance, neuropathic component to it. So we want to make sure that we're treating patients, again, not just with narcotics, but with other potential pain management, topicals, etc., if appropriate, because then it's a bit like a broad spectrum antibiotic. You're kind of hitting different kind of modalities or problems, pain problems, and then again, potentially reducing your opioid use. So this is just some evidence to support this. This is actually an inpatient study that looked at total joint arthroplasty at the knee and hip. And this was a very large study, and they compared using opioids alone versus opioids plus one modality, additional modality, or opioids plus a second modality. And they found that the opioid only group did have a longer stay, and it was a more costly stay than if they when other modalities were added. And so for each modality, actually, there was a decrease in respiratory complications, a decrease in GI complications, and there was also a decrease in length of stay. So this is just a small plug about acetaminophen. I'll spend 1 second on it. But a lot of patients, and I think we do a much better job now, especially at least in our clinic, in making sure that we're prescribing acetaminophen along with opioids, and we're doing it in a scheduled way, and we're doing it at a dose that is impactful. A lot of patients, will say, "Oh, this is not helping me at all," but oftentimes they're using it intermittently. They're using just the regular strength acetaminophen. So they really haven't used it or been prescribed it in a way that is helpful. They did look at a postoperative pain study in which a third of those patients actually said that when they were given acetaminophen, that it actually did reduce pain in a significant way to them. So all these things have been put in place, DEA, CDC recommendations and guidelines, and our individual attention to trying to reduce opioid use. So how are we doing? So one area that there still is shown to be a bit of a problem is in transitions of care, which typically for our elderly population, that is kind of a vulnerable area for them, medication-wise. But they did look, or there was a study that looked at patients who had not been prescribed an opioid in the last 24 hours. But almost 50% of those patients were prescribed opioids on their discharge. And this happens with other medications as well. So PPIs, our hospital did a study probably 2 years ago looking at PPIs, patients that were admitted not on a PPI, no indication for a PPI, and discharged on a PPI. So it's not just opioids, but it is something to keep in mind. I wanted to, this is not opioid specific, obviously, but with the opioid restrictions, there has been, and it's been suggested that because of the opioid restrictions that have been put in place, there has been a rise in reports of misuse of other non-scheduled medications. Why this is, I feel, significant for the elderly is because there are, for instance, these medicines that I'm mentioning here that are often prescribed in our elderly population. And so, for instance, gabapentin, it isn't infrequent that I see patients that are taking much higher doses than that are very surprising to me. So as you know, a lot of elderly patients cannot tolerate gabapentin at all at 100 or 200 milligram strengths. And I've seen patients on 1200 milligrams multiple times a day. So what's important to note about these, and just to keep our, if we're speaking about mitigating use in general of substances, these medications can fly a little bit more under the radar because they're not typically monitored by any PMP program, a prescription monitoring program, and they're not routinely found or detected in urine drug screens. So saying that, things that are red flags for us, just to, that would give us red flags, and this may be something you're doing already or well-versed on, but just as a kind of a reminder, obviously patients that look like they're over medicated will be noticed, but patients that are reporting taking larger boluses or taking all their medication kind of as a bolus versus BID or TID dosing, or stating that they're kind of in a consistent way needing higher doses, that might indicate to us that they're misusing the medicine. And there could be a bigger problem. Early requests for refills, multiple scripts for different providers. I think that is a pretty big red flag. Especially, we have, for instance, a narcotic registry here, and in our hospital, we've tried to standardize this as well. Is that we tell patients, and some clinics actually have patients write that there will not be, for this particular medicine, we will be the only clinic prescribing to you. So if they have to agree to that. So if you see patients that are, getting medications from different providers, that obviously is a red flag. The other thing, just so that we're clear and try to make sure that there aren't patients that are flying under the radar, is just a reminder that older adults may present differently than younger adults if they do have an opioid or substance use disorder. I think this was mentioned in another, 15-minute echo a couple of years ago, but elderly patients may not verbalize craving medications, but they may say, but they will potentially say they, have this entrenched habit that they've always taken this medicine for years and years and they need to have it. Our elderly patients may not necessarily develop tolerance to medications the way younger patients can. So in fact, as they get older, they can have an increase in sensitivity to certain medications, CNS medicines, including opioids. So that might be something that is missed. And then also for cognitive impaired patients, they might unintentionally be increasing doses. They might be having social issues with, or interpersonal issues with people, and not necessarily connecting that it's related to their opioid or substance use. The last thing I wanted to kind of link in is as I think there's been a lot of discussion or continued discussion about age-friendly, being at age-friendly clinic, which we are. So the idea that we're really making sure that we're encompassing what matters most to patients and focusing on medications. And when we look at opioids, it's really important, I think, to pain obviously very much matters to patients. Opioids can be used in a safe manner, but and be helpful cognitively as well as mobility wise, but they also can be very detrimental as well. And when we talk about multidisciplinary, as we were talking about multimodal kind of approaches, multidisciplinary to me is also multimodal in the sense that we have a group of professionals that all are working together in different ways to help optimize pain control for our patients. And this quote I really like because I love, empowering our patients, because I think that is the most successful way for things to move in the direction that we would like it to move in. And that is more than 90% of our patients are willing to stop a medication if their doctor says it's possible. So just, giving good examples, for instance, and actually this is part of the requirement in our state for patients that are on chronic pain management. They have to give, they're required to be given a one-time pamphlet talking about the, obviously the risks of being on opioids. So, discussing with patients about that, but then also just testimonials about patients who are feeling better. Quality of life is actually better off of narcotics is also, I think, a great discussion. I know it's often hard to fit that in, but very, very much worthwhile.